with the clear mission and purpose to treat rare and common neurodegenerative diseases by restoring the vigilance of microglia, the brain's sentinel immune cells. We're seeing, while doing so, to employ like everything we have available in terms of like different modalities and specifically also in precision medicine-based approaches to inform our clinical development programs. And with regard to the clinical program, at this stage, we have our current lead candidate, VGL101, which is a targeted fully human monoclonal antibody against the TREM2 receptor in clinical development as a potential treatment for ALSP, or adult onset leukoencephalopathy with axonal spheroids and pigmented glia. The current program consists of 3 clinical studies. So we have a phase 1 clinical trial in healthy volunteers. We have an ongoing natural history study, and we have, which just started at the end of last year, an ongoing phase 2 trial for patients with ALSP. And I will talk a little bit more in detail about those in the following. First, a few words on ALSP. So ALSP is a rare autosomal dominant leukodystrophy caused by a mutation in the CSF1R gene, which ultimately leads to dysfunction of microglia. It was previously known as pigmentary orthochromatic leukodystrophy, or POLD, or also known as hereditary diffuse leukoencephalopathy with spheroids, or HDLS. ALSP, since a few years now, is the preferred term as it best recognizes the underlying pathological hallmarks of this condition. ALSP accounts for approximately 10% of adult onset leukodystrophies. It has a rapid disease progression, and to date, there are no approved therapies available. So, since this is a relatively newly recognized condition with the underlying gene identified around like 2012, we conducted a few retrospective reviews to better understand ALSP. One thing we did, listed here on the left-hand side, is a review of medical records of 57 ALSP patients. And I think what becomes obvious looking here at the table listing the initial symptoms patients presented with is that ALSP is a heterogeneous condition, with the key symptom domains affected like cognitive impairment, psychiatric symptoms, and also motor impairment. In another retrospective Medline review, which included close to 300 cases of ALSP patients, that's listed here in the graph on the right-hand side, we kind of found confirmation for this heterogeneous phenotype in a way that only a little over 30% of patients received a correct initial diagnosis, and that more than 40% of patients in this review were diagnosed with other conditions, including FTD as the biggest portion there, but also MS, other leukodystrophies, and other conditions. We furthermore looked like what are the actual key domains for disease progression, symptom domains of relevance. And again, like looking at those 57 case reports, similar to the initial presentation, the main symptoms prominent during progression lay in the areas of like cognitive impairment and psychiatric symptoms throughout. So, and while you can learn a lot by performing those retrospective reviews, there are still like a lot of like knowledge gaps left we are trying to fill. And one way we are trying to do this is the Illuminate Natural History study, which we have now started a little over a year ago for individuals living with ALSP. The Illuminate study is set up as a study to longitudinally assess ALSP patients and also assess like some of the caregiver relevant items through like over time, and is set up as a global study with a few sites here in the United States, site in Canada, sites in Germany, Netherlands, and in the UK. patients or individuals living with ALSP who are older than 18 years of age have a confirmed CSF1R gene mutation and are either symptomatic with ALSP, so have 2 or more symptoms of ALSP, can enroll into the natural history study, but also individuals who have what we call prodromal ALSP, meaning over 18 years of age, have a confirmed CSF1R mutation, and in addition have MRI findings consistent with ALSP, but not yet the full clinical picture and symptoms developed of ALSP. Those individuals can also enroll, and that's certainly a very important cohort also to understand like the disease transition over time better. Otherwise, it is set up in line with what you will find for other natural history studies. So we have a visit every 6 months. The study is set up for at least 5 study visits. And at those visits, we collect blood samples, MRIs, CSF, and a battery of like clinical questionnaires, clinical exams, cognitive assessments, and those type of things. For individuals who would like to participate in the trial but do not live like close to any of our trial sites, there is an option to ask for like travel assistance and stipends in order to make participation possible. So now I would like to switch gears a little bit and speak about VGL101 and the more closely related clinical studies to our lead asset. First, a few words on microglia. So microglia are the sentinel immune cells in the brain. They basically sense and act as like damage sensors and respond to any kind of like old infection, cell debris, myelin turnover in general, and then initiate a cascade of like further downstream processes to address like whatever the issue is. And conversely, dysfunction of microglia is known to be related to rare conditions such as ALSP or Nasu-Hakula, for example. But on the other hand, there is also increasing evidence for relationship or association with larger neurodegenerative conditions, including Alzheimer's disease. So question is now like, what do we know about microglia and in ALSP in particular? I said ALSP is caused by a mutation in the CSF1R gene, which ultimately codes for the CSF1R receptor. And the CSF1R receptor is a simplified way like a very important key contributor to microglial health and important for overall microglial health. And as shown here, like on the right-hand side, if microglia becomes dysfunctional, then ultimately it leads to like all these, in the meanwhile, known like downstream processes in ALSP, and ultimately causes the white matter lesions and the symptoms of ALSP. Among others, there is one other key receptor expressed on microglia, and that is the TREM2 receptor, or triggering receptor expressed on myeloid cells 2. And the antibody VGL101 is specifically designed to target and activate TREM2 receptors. And given that we know that the CSF1R receptor and the TREM2 receptor, as it's shown, and the graph may be a little complicated, but what it ultimately says is that the CSF1R receptor and the TREM2 receptor both signal through similar pathways or common signaling pathway. And thereby, we believe that we can, by activating TREM2, activating microglia, we can compensate for the loss of function induced by the dysfunctional CSF1R receptor. And that ultimately is the underlying mechanism we think, for VGL101 in ALSP. So with this knowledge, we have taken VGL101 into a first-in-human healthy volunteer trial set up to determine safety tolerability primarily, but also to characterize the pharmacokinetics, so the metabolism, the pharmacodynamics, meaning looking at specific biomarkers, and also the immunogenicity, so to see if there are any specific reactions of the body towards the antibody. And what we have learned from this phase 1 study, which has now completed enrollment, is that VGL101 has been generally safe and well tolerated at the doses we have studied. The pharmacokinetic and pharmacodynamic profile we have seen clearly supports a once-a-month dosing paradigm. So it's an IV infusion every month. And most importantly, we have seen clear indication of pharmacological activity, specifically target engagement at the TREM2 receptor and engagement of microglia. So with this, we have then in December of last year been able to start our first clinical trial in ALSP, which we call the IGNITE trial. The trial is set up to primarily assess the safety and efficacy of VGL1 in ALSP. It is also conducted as a global clinical trial with sites here in the US, sites in Germany, Netherlands, and the UK. And as you can see here on the top, it is set up, showing you here the study design. It is set up as a trial starting like with a screening period of about like 4 weeks, which then leads into a 12-month treatment period. After the treatment period, there is an option to continue the experimental treatment with VGL101 or to leave the study at this point. The study is planned to enroll up to 15 patients with ALSP. Concerning the outcomes and the time points, we will conduct what we call like a primary analysis after all subjects have completed 6 months, and then there will be a final analysis after everybody has completed 12 months. And right now, we are looking forward to report our term update from the first 6 subjects after completing 6 months, which will fall into the plan to fall into the 4th quarter of this year. Concerning the in- and exclusion criteria, key inclusion criteria for this trial are documentation of the CFS1R gene mutation and clinical symptoms consistent with ALSP. So we're asking for 2 or more typical symptoms of ALSP in order to meet the eligibility criterion. Additionally, there need to be MRI findings present also in accordance with what you would expect for ALSP. Key exclusion criteria are primarily for us like other neurological conditions which could either pose a risk or could interfere and mimic the symptoms of ALSP. And then certainly like other medical conditions which would pose difficulty for the study participation. Concerning objectives and outcomes, the primary outcome is safety and tolerability of VGL101. And then secondary outcomes are to evaluate changes from baseline in the MRI scans and also the CSF biomarkers. And then certainly to also evaluate as exploratory outcomes like a battery of clinical measures we have included that entails like cognitive assessments, specifically here the MoCA or CDR, motor assessments, and then a list of like functional psychiatric and patient and caregiver related outcomes. Yeah, for anybody interested to find out more information, we just listed the key links here, but you can also like ask me directly or one of my colleagues here. Be happy to provide more information if wanted. And before I close, another exciting initiative I just wanted to mention is our ALSP Aware program. ALSP Aware is the Vigil sponsored genetic testing program for ALSP, CFS1R mutation specifically. It is set up as a no-cost genetic testing initiative. It was launched in May of this year, primarily based on feedback we have received from the community. Namely, what we consistently heard is that it's very difficult for many to actually get access to genetic testing, and then even if there were getting reimbursed for those genetic tests, and that's something which for many kind of led them away from genetic testing, specifically if it's family members, and then they kind of postponed it for unforeseeable future. And so that's why we started this initiative. It is set up basically with two components. The first component is a single gene test option for CSF1R. So that's primarily relevant for family members of ALSP patients where there is a known CSF1R mutation in the family. And then secondly, there's also a test panel option, which is open for participating physicians, where they could refer potential patients where there is a leukodystrophy with possible suspicion of ALSP somewhere in the background. Just from a practical perspective, the program is set up in collaboration with Informed DNA. We were happy to kind of collaborate with them on this. I think they have a really highly trained group of genetic counselors, and for any interested patient, the process will be that there will be an initial consultation with one of the genetic counselors. They will collect general medical history and other kind of relevant information. Also discuss the genetic disorders in general, the gravity of genetic disorders and of ALSP in particular. And also then review pros and cons for getting a genetic test. If somebody decides to undergo genetic testing, then the counselors will kind of coordinate everything. And then there's a follow-up appointment where they will review the results and also kind of see what the next step could be for a given individual, plus provide a written summary of the discussion and the test print out for other healthcare practitioners who might become involved. Yeah, so that's open now and has been off to a good start over the past 2 months, and hopefully that's something where also more individuals will have the opportunity over the next coming month to get confirmation if they are CSF1R positive or not, if that is a question. So yeah, with that, I would like to thank you and happy to answer any questions if there are.
Perfect. I think we have time for a question or two if anyone has anything. No. We have a mic. Well, I'll repeat it because the online people can't hear. Okay. So the question was if he was specifically looking for people with leukodystrophies versus frontotemporal dementia.
Yeah, simple answer. That's a yes. So I said the program is set up in a way that there's a single gene test option. And has been relevant already for people where they know there's a family member who has been diagnosed with it before. So that's one option. And then the panel option, which is a little over 20 individual genes being tested. They are mostly leukodystrophy specific. There are C9 orphan we are looking for some related to FTD, but it's not tailored towards FTD, but more to leukodystrophies and specifically looking for CSF1R.
Mm-hmm.
Yeah, sorry. So I worry because and I know I've told you this, but just so the larger community knows that, if the majority of patients, and I think on your slides too, present with frontal temporal dementia, many patients go to frontal temporal dementia specialists that we've heard, and they can't get genetic testing. And then even if they do get genetic testing, so since I'm a little crazy, I looked it up, and there's like 2 panels that do include it, but they're not ones that we would they're not companies we would use. So I just think that that's probably where these patients are living. And once they get to a leukodystrophy specialist, we're gonna figure out what they have. So I worry that that's where the higher yield is for finding patients that are getting missed.
Yeah, I completely agree with that. I mean, that's also like from I think our observations, that it's where like many patients get stuck at least for a while until it becomes clear this is that's not a typical case of MS, for example, or a typical case of FTD, and the imaging looks kind of different from what I would expect. And having more awareness around this, having like those genes included in like general panels, that is certainly something which I think is highly important. Like from our perspective, the primary driver for setting this up was really like what we heard from like patient organization and from like individual patients. And that's primarily like where we were coming from. But ultimately, in order to improve the diagnosis of ALSP and other like rare leukodystrophies, specifically in adult onset settings where this kind of screening is a little bit less organized than in other settings, that is certainly something to kind of work on in the years to come and kind of to improve that.
I have a question back here. You may have mentioned this, but in the natural history study, do you accept patients who have received stem cell transplant already, or is that an exclusion?
Yeah, for the natural history study, we do, yes.
Sorry. Yeah, there is what in line with what Katie just said, because most of these patients do tend to present with a dementia type of picture. I wonder, have you reached out to the ADRCs, the Alzheimer's Disease Research Centers? There's that's like a 30 different centers across the country that focus on Alzheimer's. Because I have talked to the one at Hopkins, and there's an ADRC at Hopkins, which is connected with NIMH and NIA. And they're like, what, genetic testing? No, we don't do that. It's just like, what are you talking about? Yeah. So I just wonder, do you have an active trial that whether there would be a way to advocate those there?
Yeah, I mean, first and foremost, like I can echo, like that's our experience as well, that many, and I mean, there hasn't really been a reason either to do a lot of genetic testing, like in many subspecialties. But that's certainly something like we are working on and trying to increase awareness and trying to collaborate also like with colleagues in different sub branches of neurology, like specifically in the dementia field, like MS is relevant. So that's certainly something we are very interested in and are working on.